So today I was asked to talk about imaging of prostate cancer in patients following definitive therapy, so a little different. And we heard, here are my disclosures. First ARS question. The best FDA-approved tool for detecting metastatic disease is A, Prostate, B, PSMA PET-CT, Fluciclovine PET-CT, sodium fluoride PET-CT, or C11 choline PET-CT. All right, great. So all right, hopefully we'll clear this up at the end of this talk. Great, so the objectives are to talk about the detection of recurrent disease and metastatic disease, and we really divide this into two areas. For local disease, we're going to talk briefly about multi-parametric MRI, and for advanced disease, we're going to talk about PET-CT. In reality, I think there is a little bit of overlap, and I think that overlap is going to grow as we learn more about these different imaging agents. But we're just going to spend a little bit of time on prostate MR because it was covered so well this morning. So for local disease, we're really talking about multi-parametric MRI. And just as a side note, I think Robert and Michael did an amazing job talking about really the whole spectrum of the use of prostate MR up front and how it sort of integrates with this idea of MR-guided biopsies. I think, the data is always so heterogeneous. And I think the problem that we have with a lot of these imaging studies is they're retrospective, they're single site, heterogeneous patient populations, protocols are different. I mean, just endless amounts of errors that really just doesn't create pure data that I think is difficult. And that's why we see a lot of different papers that talk about sensitivities in the 60% range, and then another paper that talks about in the 90-some% range. I think that's a huge problem. I think quality MRI, not just in the community, in academic settings too, I think is difficult. So, PIRADS was created to help solve this. And I just recently gave a talk about controversies in prostate cancer imaging, and I think that's a huge take-home message, is that we talk about prostate MR like it's a great tool, and it is, but there are real issues with quality. So I think PIRADS is a great tool to help standardize the technical protocols and standardize the interpretation of these. But in reality, I think probably 80% of the people in this room, when you order a prostate MR, I don't think you're getting PIRADS. And I think that's a problem, and I think we need to demand that and expect that from our various radiology groups to give us the product that I think is a higher quality product. So anyway, we're going to talk about multi-parametric MRI in the setting of local recurrence, and that's for the use of MRI in patients who have biochemical failure after radical prostatectomy and radiation, and it could evaluate for local recurrence versus normal tissue versus scar, and it could help guide biopsies. So this is a meta-analysis, and this is, about prostate MR up front. And since we've heard about this already, I just wanted to make the statement that it is a good tool, and this is an ROC curve, and it's clearly not along this line, because if it's along this line, that means the test is useless. So I think it is a good tool. We just need to find the right place for it. All right, in local recurrence, which is part of the AUA guidelines, it is indicated to get a multi-parametric MRI. So this is one study that looked at 187 men who underwent MP-MRI followed by truth-guided biopsies of the prostatic fossa. Local recurrence was detected in 132 of those 187 patients, and the median PSA in those patients was 0.59. Median lesion size was 1. And I agree, small lesions are difficult to detect because of the resolution capabilities. But overall, the sensitivity, specificity, positive predictive value, negative predictive value were good. But in this case, the specificity wasn't quite as good. And I think the reason why is because sometimes you get scarring, you get post-surgical changes, inflammation, and things like that, that could be interpreted as local recurrence, but may not prove to be. For local recurrence, PIRADS is not the way they're read because it's just not meant for the use in local recurrence. So the conclusion is it helps target biopsies to more accurately diagnose radiation failure and to possibly determine who may benefit from more local or focal salvage therapy. All right, so we'll sort of fast forward and talk about metastatic disease. And when we're talking about detecting metastatic disease, we're really focusing on two things. We want to detect disease in bones, and we want to detect disease in soft tissues. And this is the chart from the RADAR group recommendations, which was published in Urology, chaired by Dr. Crawford in March of 2014. It doesn't really project well, but it basically creates 3 buckets with regards to the patients in different stages. So newly diagnosed patients, biochemically recurrent patients, and M0 CRPC patients. And it gives recommendations with regards to how you should image them and when you should image them. And this was based on just using bone scans and CTs. And in that article that we published in 2014, we met, I think, in 2013, we discussed the advanced PET imaging tools that were available, but they just weren't ready for prime time. So we're just going to go over a little bit about the history of imaging and talk about what's available today and how we could sort of take that home and practice a little differently in the future. So bone scans have been great. They've been around for decades. So they were first FDA approved in the 1970s, and we've been using them every day for decades. I think we saw a real change in practice in 2012 when C11 choline PET-CT was approved. The biggest problem, though, was that no one in this room had access to this. That approval was basically limited to the Mayo Clinic in Rochester because they had a cyclotron. That NDA was specific for their facility. So though we read about it, there was a lot of buzz about this, you couldn't get it. And I think that was extremely frustrating. Fast forward 4 years, 2016, we have a new radiopharmaceutical called F18 Fluciclovine. It's called Axumin. It now is available in a lot of markets. I think right now probably 17 or 18 different markets have this available. And we'll talk about that a little later. So bone scans, they're planar images. They're 2D. They're just, you take a picture from the front, a picture from the back. Again, 1970s. It uses bisphosphonates. The nice advantage to this is it can image the whole body, but the downfall is it only images the bone. It doesn't image the soft tissues. And the other big disadvantage of bone scan is that it is imaging the bony response to that your bones have, not the disease itself. So, when a metastatic lesion lodges itself somewhere, it creates this bony response, this reparative response, and that's what it's capturing. So that's why we talk a lot about flare with these bone scans. Then CT came along in 1971, and this was great as it developed because it could detect soft tissue disease and lytic bone mets and sclerotic bone mets. But typically we would see bony lesions a little later than we would with a bone scan. Sodium fluoride PET-CT, though we've talked about it a little more over the past 5 years, it was actually first approved in 1972. And the advantage was that it was whole body imaging. It used PET-CT, which gives you better resolution, but the disadvantage was it was bone only. But when it came to imaging the bone, it was a bone scan on steroids because it was just really, really much better. So this was a case of a bone scan that was read as negative, and I agree. But patient had high-grade, high-risk prostate cancer, elevated PSA. Sodium fluoride PET-CT just showed a numerous number of mets in the axial and proximal appendicular skeleton that the bone scan missed. Whole body MRI. This is something that we read a little about. In the U.S., it's not really available, but in Europe, it is included in the guidelines, of the European guidelines. The data with whole body MRI for detecting bony disease is actually very good. I think the biggest problem is the protocols vary from site to site. Granted, there are papers out there that have talked about a standardized protocol, but they're just not implemented. And in the US, there's no code for this. So if you imagine doing a protocol on a patient whole body in an MR scanner, as an administrator, I have to tie up that scanner for an hour, hour and a half, 2 hours. Granted, some you could tailor to protocols, but that's a lot of lost revenue. And in the U.S., again, it's just not something that we have a code for. It's not reimbursable for us. Maybe there might be a handful, not even a handful, maybe 1 or 2 trials that might be using this in the U.S. It's possible for us to tailor this to detect soft tissue disease, but again, our protocol then is going to get even longer, and that's just not feasible at the moment. So version 2.0, this is when we had technologies to image bone and soft tissues in one exam. And the first test that actually did this, which was the first PSMA imaging agent, was Prostate. First approved in 1996. It uses the PSMA molecule, and it images bone and soft tissues. The problem was it didn't use PET-CT, it used a gamma camera. and it was removed from the NCCN guidelines recently. I think this was just not the best test because you had to image over several days, so it wasn't convenient for patients. And I think the biggest problem was the PSMA molecule, the monoclonal antibody, attached to an internal epitope of PSMA, not an external epitope. So basically, the cell had to be dying or necrotic in order for this radiotracer to see the internal epitope that it needed to attach to. So I think for a variety of reasons, it just sort of fell out of favor. And I would argue, in 2017, we should no longer be discussing Prostate. So hopefully, we could put that to bed. But we've made some significant advancements, and this is what I like to call version 2.1. It's imaging bone and soft tissues in one exam using PET-CT, radiopharmaceuticals and PET-CT. So when we talk about PET-CT, we're really talking about a modality. And then the app that we insert into it is the radiopharmaceutical, and that is what provides the functionality, the output of any PET-CT exam. So similar to an iPhone and an app, the iPhone is the computer, the machine that runs it, and you could do whatever you want on that iPhone as long as you have the proper or applicable application. So the first PET radiopharmaceutical that was developed clinically was FDG. That was a glucose analog. It was FDA approved in 1997. It had real limited use in prostate cancer because what we knew, though, in prostate cancer was at initial diagnosis and even at biochemical recurrence, the prostate cancer cells had relative lower use of glucose utilization. At the University of Colorado, some of my research in tandem with multiple people there was to somehow alter the metabolism of these prostate cancer cells to make them use more glucose, but we weren't able to do that successfully. One of the limitations also is the fact that the FDG gets excreted by the genitourinary system. So you get a lot of activity in the bladder, and that bladder could obscure the prostate and whatnot. And another disadvantage of FDG is that inflammation, infection, those white blood cells use a lot of glucose. So oftentimes you get a lot of false positives because of an infection or inflammation. And your body actually has a lot of inflammation at various times. So version 2.2, C11 choline. This was a game changer again. FDA approved in 2012, used PET-CT, and it was indicated in patients who were biochemically recurrent, who had non-additive or inconclusive imaging with bone scans and PET-CTs and other imaging tests. It was incorporated into the NCCN guidelines a couple years ago, but the biggest problem here was limited availability. That C11 isotope only has a half-life of 20 minutes. So if it only has a half-life of 20 minutes, you basically need an on-site cyclotron in order to produce it, transport it, inject it, and get the patient imaged. And that's why Mayo and Rochester was the first and only to have this in that clinical setting. It was available at other places under an IND, cost recovery, but it was expensive. I think there was good data regarding the use of C11 choline. The sensitivities and specificities, these don't project well, but multiple studies showing that it had improved detection compared to other bone scans. And this lists a bunch of other single-site studies that talked about the use of C11 choline. A lot of this comes out of Europe and, again, the Mayo Clinic. But, again, single-site, the data isn't quite the level that we have for a lot of our other clinical trials. Again, we talked about the limitations, but because of that 20-minute half-life, it really did not it limited its commercialization. So at the University of Colorado, we actually had a cyclotron, and we tried to produce this and commercialize this ourselves just internally, but the costs up front were just too much to overcome. So 2.3, this is where we actually have something that is commercializable. All right, show me the money. This is Fluciclovine, trade name Axiom. It was FDA approved in 2016. And its label, this comes directly from the FDA label, suspected prostate cancer recurrence based on elevated PSA levels following prior treatment. I think when we zero in on that, we think biochemical recurrence. But I think we could expand it, as you see fit, because it's actually pretty broad in my opinion. It's a synthetic amino acid analog actively transported into the cell via these transporters. Doesn't get metabolized, and it stays in the cell. So once that F18 isotope gets its way into the cell, it starts emitting this positron, which undergoes this annihilation reaction, which then our cameras can capture and create these real pretty images. So they did this comes from Emory University, and they did some head-to-head trials of fluciclovine versus Prostate. And you could see that the sensitivity was better than Prostate for local disease and for extraprostatic disease. Specificity was better here. I guess it was a little worse compared to Prostate locally. And basically the positive predictive value, accuracy was better. Overall, just a good test. When you compared it to CT scans at varying PSA levels, it shows here that the fluciclovine was much better than the CT scan at all PSA levels. And this isn't surprising because a PET-CT using fluciclovine is basically a CT scan with a radiopharmaceutical as opposed to just a CT scan. So this comes from Italy, from Nani and colleagues. This compared fluciclovine versus choline head-to-head in a prospective study with 50 patients, single site. And basically, the fluciclovine picked up disease in more patients than choline did, and it picked up more lesions in those patients than choline did. And then when we distributed it by PSA levels, it also performed a little better than choline. So the basic conclusion here is that it's as good as choline for detecting recurrent disease. Another study that was published in the journal Urology recently talks about the detection of disease in the prostate bed, outside of the prostate, and whole body at various PSA levels. And at a PSA level of less than 0.79, it shows its detection rate in the whole body just over 41% using fluciclovine. So I think it's a very, in terms of performance, it actually performs very well. And I don't think we've ever had a diagnostic agent, imaging agent, that could detect recurrent disease at those low PSA levels. So I think the big question, though, is this just all lead time bias? Who cares? We have these tools that could detect disease. Who cares? Is it going to change outcomes? And I'll tell you, that's a hard question, because this is a diagnostic test, and what happens after that, it's hard to track all that and really attribute a certain benefit to a diagnostic tool that occurred upstream. So granted, slide was for screening, but what we really need to show is that we detect the disease sooner and death occurs later. And we're not there yet, but I think that's the direction we need to be headed. But again, I don't know if that's realistic for an imaging test. So I'll show you some data that shows its ability to maybe have some value in our clinics. This is a study that was published in J&M in 2017, talks about the impact of fluciclovine PET on target volume definition for post-prostatectomy salvage radiotherapy. And their end conclusion was that there were significant differences in target volume, higher doses to the penile bulb. And Dr. Beyer shared the information from the Falcon trial that was just released at Astro. And that talked about, again, changes in that radiation planning. And I believe a secondary endpoint of that Falcon trial is looking at response to salvage radiation. And those have not been released yet, but I think that'll be interesting to see as well. This is change in salvage radiotherapy. 87 patients, 42 were randomized to fluciclovine, 42 had positive findings. Similar to what Dr. Beyer showed, radiotherapy decisions changed in 17 of those 42 patients. 2 did not get radiation because they had extrapelvic disease, and the radiation field changed in 15 of those patients. So this idea of change in management, I think, is real. So that Falcon trial showed 61.5% change in management, significant change in management. When we look at data from gallium-68 PSMA, it showed a change in management in 53% of patients. And another PSMA agent using a small molecule showed change in management in 51% of patients. So I think, these are clearly changing management, but again, what does that do to outcomes? And I don't think we know yet. So this is a sort of a table that I put together that talks about the imaging tools that we have available and the Medicare coverage. So Tech99 bone scans, they're good for bony disease. They're not good for soft tissue disease, but they are covered by Medicare. CT scans can detect bone disease. They're not as good as a bone scan because we're waiting for that sclerotic reaction. But they do detect soft tissue disease and visceral and metastatic disease. They are covered by Medicare. Whole body MRI, very good for detecting bony disease. Soft tissue disease, we're not sure. It depends on the protocol. But in the US, it is not covered by Medicare. Sodium fluoride PET-CT is great for bones, doesn't really detect soft tissue disease. It's been covered under the National Oncologic PET Registry for the past 3 years. So this is sort of breaking news. If you have been ordering sodium fluoride PET-CT, you have until December 14th. Because after December 14th, the NOPR registry is going to close. And CMS indicated that they're not planning on renewing it. So what will happen is the data will be, analyzed, and they'll make a final decision whether they cover it or not in the future. Personally, I don't think it's going to be covered. So I think you have until you have 3 or 4 weeks to get your last sodium fluoride PET-CTs in. FDG PET-CT, bones, soft tissues, not great. Patients with later stage disease, more advanced disease, I think FDG PET-CT gets better. It's Medicare. It is covered by Medicare, but it's only covered for patients who are getting subsequent treatment strategy scans, so patients where you're looking for a response to therapy. C11 choline is great for bone, great for soft tissues. It is paid for by Medicare, but it's limited. F18 Fluciclovine PET-CT is great for bone, great for soft tissues. It is covered by Medicare. PSMA, I put 4 pluses for this because based on the data thus far, it's probably the best for bone and soft tissues, but it is not covered by Medicare. It is not FDA approved. That being said, it's widely used in Australia and widely used in Europe. In the US, there are a few, mostly university medical centers that now have INDs for this, that will be offering this under an IND cost recovery program. And when I met with some people from UCSF this past week, the number I was being quoted was around $1,500 to get this scan. So if you have any patients who are interested, you could refer them to UCSF, University of Wisconsin, I think maybe Sloan Kettering or Cornell to get these scans for some out-of-pocket costs. So if we go back to the RADAR guidelines, for newly diagnosed patients, I guess we could use sodium fluoride, but we only have 3 weeks left to use it. PSMA is not covered by Medicare. It's not FDA approved yet. However, if you have a patient with high-risk disease, you really think they might have metastatic disease and you have a negative bone scan and CT, and they have the means to pay for it, maybe it might be worth, paying to get a PSMA scan up front. And this is sort of the next area of research for a lot of the companies, is figuring out how these advanced PET pharmaceuticals perform in the initial diagnosis setting. For patients with biochemical recurrence, I think our best bet right now is going to be fluciclovine PET-CT versus choline PET-CT. And those are approved by the FDA and available and reimbursed. For patients with M0 CRPC, I think it's sort of yet to be seen. FDG, could be used. Fluciclovine, I don't think we talk about much in that space, but I think it does have a role there. PSMA PET-CT could be used there. Sodium fluoride, again, limited, and choline. So the conclusion, advanced imaging tools such as multi-parametric MRI and PET-CT, they're far better than the traditional methods that we've had available to us. The conclusion here is they're here to stay, So it's really up to all of us to figure out how best to use them and incorporate them into our practices. And the last conclusion is I think it's important that, you get to know your radiologist, get to know who they are, what their specialties are, what their subspecialties are, and expect and demand a little more from them. I think the radiologists are here to support your practice as a urologist or an oncologist. So I think it's important to develop that working relationship and that communication. And if you actually read the AUA guidelines about multi-parametric MRI, it actually includes a paragraph about that communication circle and that feedback circle, how it benefits both sides. And Dr. Cookson alluded to that as well. So I'm running out of time. I'll make up time on the other lectures, but just quick cases. Here's a 80-year-old man, Gleason 3+3 treated. He had a PSA of 6.5. His PSA rose a few years later. Patient got an MRI. It was read as indeterminate. They talked about this little area here. They didn't use PIRADS, and again, this happens all the time. We got an Axiom PET-CT, showed this focal area right there, biopsied, proven to be recurrent disease. Another case, Gleason 3+4, treated with EBRT in 2012. PSA started to rise. The bone scan was negative. They got a prostate MRI, showed this odd lesion here in the right pubic bone, sort of hedged whether it was met or not. I don't think I was really buying it. We got an Axiom PET CT. What we did find was there was a left external iliac node that was lighting up, or internal iliac node, which on CT you could actually see, but without contrast, it's sort of hard to detect that. And that bone lesion didn't have any uptake, so I did not think it was metastatic disease. This was another patient, bone scan and CT were negative. Got a Fluciclovine PET CT, showed this new focus of uptake here in the right pubic symphysis. There was a little sclerotic focus there on CT, which, I thought to myself, I tried to give the patient the benefit of the doubt. Is that just some inflammation, some degenerative disease? Went back in the patient's jacket. 2 years ago, had a CT scan. There was nothing there. So I think this ended up being metastatic. At least we treated it. We couldn't biopsy it. And they also had a focus of recurrent disease in the right seminal vesicle. So I think this is going to bring up a lot of questions in the future that we could talk about with regards to how you treat oligometastatic disease and what you do, especially since you won't be able to biopsy a lot of these lesions. And, we don't have those answers yet. Anecdotally, I know that in Australia and some of these places that are using PSMA are doing extended lymphadenectomies. They're increasing their radiation fields. And with those extended lymphadenectomies, we might see more lymphedema that we haven't seen in the past. So I think these are all questions that we need to work on together. But again, I think this tool is here to stay.